Good afternoon and welcome. Thank you for being here. I appreciate you taking some time out of your day to spend some time with me. Today I get to talk about one of my favorite things, and that's how teeth hit each other. Occlusion has always been one of my favorite subjects, and today we get to talk. Sorry, that just muted me, okay? What equilibration kind of has come to mean for me is building an occlusion, designing an occlusion. And so when I start to think about that, let's talk about what the components of a designed occlusion are as part of our thought process around equilibration. When I was younger, my belief was, well, equilibration was about grinding on teeth. And I'd like to try and introduce you to a little bit of a different paradigm. And I know we have some experts who are watching me. And so, Darren, nice to have you here. You could be doing this. You should be doing this. Let's start with this one. The condyle and the disc have to be appropriately positioned if you're going to design something. And appropriately is an interesting word. We kind of get to decide. I would tell you my personal preference is going to be centric relation, ball in the cup. When the muscles are fired, the condyle moves up into position, up in the fossa, and that is a terminal kind of a position. I happen to like that one. We call that centric relation, although the term has so much baggage. For me, it just means that it's a stable position with the condyle seated into the fossa. There's another possibility. You could use maximum intercuspal position to be the position where they are as you design things. If that's the case, you're going to count on teeth to tell you where that is. And then lastly, there's another way. You could use muscles to determine that. I believe that the one that is the most stable over time is going to be my understanding of centric relation, which is kind of ball in the socket. It's a seated position. Not everybody can have that, however. Here's how you would find it. Okay, if I want to find it, I want those muscles to fire and seat that ball, but there's a number of ways to do it. We teach three here. The first one is to use a leaf gauge. And on the leaf gauge, I can have the patient move forward, slide back. And what I'm trying to do is take the teeth out of the loop, allow the mandible to move, and realize it doesn't have to worry about how teeth hit, and allow it to seat. And when I do that, I can then capture that seated position. I can use a Lucia jig, and I can do the same thing here. I can ask the patient to slide forward and back. In this case, they would be sliding on a flat surface. Flat surfaces offer almost no resistance, and so they can move comfortably and freely. And then we go out and back, and we do the same thing, all the way forward, all the way back. And again, going to that seated or terminal position because teeth are not involved in this. There's another way that we could do it. We can ask the patient to arc. Okay, and we can use bilateral manipulation or bimanual guidance, depending on the term you like for that, in which case I can ride along and feel that teeth are not involved, that the condyle seated, that muscles aren't firing, and I have a terminal hinge position that is comfortable. And actually, people can be loaded there. Those are the three ways that I know how to do it, but here's what we're trying to figure out. Imagine that your mandible is a door, and the door is swinging. And as the door swings, okay, and comes closer to hitting something, something's going to happen. There are hinges involved in that, okay? And so if we think of the mandible as the door, the condyles start to become the hinges. Those are the things that are being hinged around. For me, when condyles seat in that terminal position, I'm counting on that information to tell me where that hinge position is. It doesn't involve teeth. And if you think about, we don't screw those hinges in, but for all intents and purposes, the muscles are the screws that hold the hinge in place. And they seat that, okay? Teeth are not involved. And that's an important consideration when we think about appropriately positioning the condyles. Where do you want to plan from? Years ago, I used to believe my mission was to get people's teeth to conform to having those condyles fully seated at centric relation. I don't necessarily believe that anymore. And I'll come to that along the way. What I believe today is that for me, when I have to make a plan, centric relation for me is the most reliable place to plan from. And equilibration or designing an occlusion has to have a place that I start to plan from. If I'm going to use that terminal seated position, here's what I'm thinking. I'd like to be able to hinge up, have an arc of closure, and then watch the green line go up. That green line is showing that cusp is going to come up and it's going to hit nicely in its receiving area. That's my goal. I want everything to hit. Come back to that. I want to use this term because sometimes you will hear it, and I'd like to tell you how I use it. For me, centric occlusion means the first tooth contact in centric relation arc of closure. In other words, if the condyle is fully seated here, and I arc, the first thing that touches is going to be centric relation occlusion or centric occlusion. But if it's not seated, okay, then I wouldn't call it centric occlusion. Now, let me just tell you the reason I say that, because as I talk about things, I want to make sure you understand what I'm saying. I'm not trying to confuse you by changing terminology. For me, the centric occlusion in this case, where the arc comes up and it hits at a different place on the tooth, and then there's a shift until all of the teeth hit, the centric occlusion is that first contact. Where all of the teeth hit, I would use the term maximum intercuspal position, MIP, or ICP for intercuspal position. So in other words, for me, centric occlusion is what touches when the condyles are fully seated. And I like to talk about it that way because centric relation then and centric occlusion is a consistent thing. MIP, maximum intercuspal position, just bite. It's been called the acquired bite. And as I said, it's been called centric occlusion, not something that I would call it anymore, personally. That is a position in which all the teeth hit. Everybody has it, or at least the maximum number of teeth hit. Patients can go there. You have them bite, they just bite. And when they bite, that's what you live with. That becomes your stable point. I think that you can see that if I'm using teeth as my stable point, I have a limiting factor. And the limiting factor is going to be that I need to do something to make sure I have enough teeth to maintain that stability. We'll come back to that. Does that mean that all the patients that I see get treated at centric relation? Heavens no. Here's a patient. You can see that they have a very steep guidance. If you look at the canines, they're nice and angled sharply. This patient is going to, the back teeth are going to move apart as soon as they move. My point in this is this person has a large shift, almost 4 millimeter shift from centric occlusion, first point of contact, with condyle seated to where everything fits. And yet, because there's no wear there, and there are no other factors that make me wonder if it's working, the only thing I would change by treating these teeth, which were caused by trauma, the damage you said was caused by trauma, there's no reason not to do that, because the back part of that occlusion is not interacting with that. What acts it is the pathway and the edge to edge. And in those cases, what you want to do is you want to try that out, okay? So if I think about that way then, MIP tells me I have to live with what I have. An interesting thing for this, have you ever seen class 3 MIP bites where if you see condyles, they're end to end? Well, that may offer you a whole different world of possibilities in therapy to change how things hit if the patient wants changes, or if you're trying to correct something functionally. Okay, very often MIP can hold you back. And then sometimes you just don't have that much MIP, and sometimes you have none. It's like, where is this? And the teeth are moving all over the place. I can't count on that position. The third one today that we could use is a muscle-mediated position that some people would call myocentric. I'm going to call it a muscle-mediated position, okay? But myocentric can be found and is taught today by going in and using a tool. And it's either it's some sort of a low frequency TENS unit. This is showing a 2-lead TENS. Today, everybody would use a 4-lead TENS. Originally, when we were doing these, we were stimulating the cranial nerves at 5 and 7 were the ones we were stimulating. And where I put the mark is where we were trying to fire so that we could fire those neurons. And then we would use some numbers that were put together by a Canadian orthodontist. And the idea was here to say, where should those front teeth be? And what size should they be? Today, this is kind of the standard. This is the LVI golden vertical, and it's determined by tooth size. Okay, and when I was learning this is what I was taught when I was at LVI. Here's what you do. You look at the width of that tooth. This happens to be 8.5 millimeters. Look at the length of this tooth. It's 9.5 millimeters. That's an 89.6% tooth proportion. What we'd like to have is not that. We'd like 77.5, and you can pick one. It's somewhere between 74 and 79, depends what you really like. Okay, most dentists like longer teeth. I do. So I picked 77.5. That means that tooth should be 11 millimeters long at that width. Okay, that's 2.5 millimeters longer than it is now, right? Now, if I measure CEJ to CEJ, well, actually free gingival margin to free gingival margin in this case, but technically CEJ to CEJ, that's a 15.25 measurement here, okay? If I know that I want to add 2.5 millimeters, the way that I change this is I say, well, now what I need to do is I need to take this vertical dimension to a point at which that measurement is now 17.75. And I can tie that into a Bowley gauge or any sort of a measurement device. And you'll see that that's what's exactly is in the list here. If you look at the list of what measurement of central and what the vertical would be, you'll find that that correlates with that. Then I would take what's called a TENS bite. I would pulse muscles to fatigue, okay? And what I'm going to try to do is to start out at the vertical dimension, bite down, measure that, 15.25. Okay, I want to get to where I have opened things up that 2.5 millimeters. So I've pulsed muscles so that they are just hanging loosely. And I want to find the point that is 2.5 millimeters open from that point, because that's how I want to change the vertical dimension. So the way that I do that is I go in, I pulse muscles to fatigue, I pulse the jaw closed with the patient. In other words, I now turn on the myomonitor in this case, which is what I'm illustrating here, and it begins to have the muscles fire. So as the muscles fire, the jaw moves, and I'm measuring in there. I stop at the predetermined vertical dimension of occlusion that I measured previously. I capture that with a bite registration, and it should be at 17.75. What I've done is captured their bite. This is actually some of my models mounted like that from that same bite. Then what I would do is I would go and say, well, I know what the front teeth need to be. Let's make the upper anterior teeth be what they need to be, a lot like in facially generated treatment planning. I want those that size. I know that I want that 17.75 between my CEJs. So what I'm going to do now is I'm going to go ahead and put models on there. Let me go back one. I'm going to put models on there, mount the models. I'm going to put the upper teeth where I want them. I'm going to open to that same exact position, and then I'm going to put the lower teeth in so that they occlude correctly. What I've just done is use the measurements that I got to go in and build that occlusion. There's another way to do it. You do a myo bite. We need more material. I'm sorry, we need more technology to do that, more equipment. We're also then going to use an EMG and a kinesiograph. And in this case, what we're going to do is we're going to go in and we're going to pulse muscles and get a baseline, and then we'll pulse them to fatigue. We do some tests along the way. Clenching, you look and make sure that they can fire more on cotton rolls, because on cotton rolls, you're a little bit open. You should be able to fire more. And how about a clench and hold? How long can you hold that muscle for? So there's a number of things you can look at with an EMG that can be really useful. We would pulse muscles until they're fatigued, and we have a screen. And the screen now is going to let us watch what happens, because the kinesiograph is recording. There's maximum intercuspal position. In fact, if you look over here where this black line is that I'm running around, that's the shape of the tooth, upper tooth, as I slide forward. And these are my measurements, okay? So that's MIP. This is my habitual path. In other words, it's just open and close, open and close. And then we pulse, okay? We pulse to fatigue, and this is my rest point. I came down to here. Once my muscles were fatigued, we could now turn on the myomonitor again, and that's the pulse path that my muscles pull. I'm not firing them, the machine is firing them. So what we do, we create in our mind an interpolated path. We say, well, that's where things want to be from rest position. If we now fire on that same line, okay, this is where things should be. If I want to have 3.2 millimeters of freeway space, where should my vertical dimension be? It should be right there. All right? And this is telling me there's 3.2 millimeters from the full rest position, and there's my VDO. Now what I would do is I would watch my monitor, pulse muscles to fatigue, verify muscle release, record the kinesiograph tracing as you saw, okay, get to the new vertical dimension that was inferred from the data, pulse the jaw as the patient closes, and stop at that VDO, capture with bite registration. Now we did this two different ways, and I'll show you they're very close. They're within 1.5 millimeters of each other. All right, one is a TENS bite, one's a myo bite. You can get to the same place. They were very close. And then what you do is you would go in and say, how could that work? And so you could make an overlay. The one on your left is a lower, looks like an appliance, and it is in many ways. It just has occlusal form on it, and it snaps in, and you say, how does that feel? Does that work? The one on your right is one that can stay fixed, and I'll just show you the one that was made for me. I made this one. So we went in and I made an upper, because tooth form, my teeth were short. I wanted them longer, and that fit the measurements. So we went in and we made that right there. I made that little device. Okay, it's like an appliance. It snaps on. I made it look like teeth. I can wear that and see how I function. How do I like that? Do I feel like I run into it? Okay, I can test the vertical dimension change. I can tell you the vertical dimension is incredibly flexible. When I was in school, I was taught that if you change the vertical dimension, you better be careful because the skies might open and God might strike you dead. Today, we don't believe that. What we know today is that the vertical dimension that will be tolerated is the one that will work for that patient, and it's highly variable. In other words, small openings sometimes don't work on someone. And so we have to test it out. Well, one of the reasons that we would test it out is to make sure that we don't change all the teeth and have a problem. Unfortunately, that's hard to check out with an appliance because people always have appliances get in the way, which is why we make an overlay, or we try to. Or if we're restoring everything anyway, we create provisionals. And for me, often full mouth provisionals become the test of a new vertical because you can go in and change things. Now, what kind of cases are most appropriate? Because I will tell you that I treat people to a muscle-mediated position. This is a patient of mine from about 18 years ago. Her name is Lisa. And when Lisa came to me, I will tell you that right now, that's where her occlusion needs to be for her to be comfortable. And what I mean by that is her mandible is positioned forward. Okay, and if I seat her condyles, which I can do, and it does not hurt her, it's not painful. However, functionally, she does not like that. She finds it truly uncomfortable and she beats up on her teeth. She doesn't like it. She pushes against it. So we worked with overlays to get to where she was comfortable, and this is where we wound up. She has contact in the anterior, and this was before I had the ability to do a lot of milling, so I actually went in and created composite overlays, which we bonded on, and she wore for a while. Now, why? Well, she has no discs. She has obviously pseudodisc in there because she can be loaded. She's become avascular and enervated. She has a history of pain. There's always a history with patients like this. And she was sort of just functioning. And where she got comfortable was a place where she could be treated. And she's been comfortable and happy for these 18 years. But let's think about this way now. Once we decide where we would like the hinge to be, okay, there's three possibilities as the door swings closed. These are the possibilities in door closing. The door swings shut smoothly, seats completely into the frame, and then latches with little or no resistance. So it's one of those doors where you swing it shut, it goes right to position, it goes click, and it's solid. You have a door like that. If you do, and you recall what it feels like to close it, I'm going to bet you would tell me that you like it. Why do we like it? Who knows? It just feels good. We like it. Okay, here is the analogy to your jaw. The jaw closes, teeth fit together completely and simultaneously in a maximum intercuspal position. There's no deflection of any teeth or of the jaw. Boom, it just goes right up and boom. And it feels good. In fact, many patients I've asked, how does it feel? And the word that I hear most commonly coming back from patients is, it feels solid. Because it's a great feeling. There's just like this clump that happens. Possibility number two, the door hits the frame moves as the door fits into it. I had a door like this in my house in Tennessee when I lived in Memphis. It was the outside one that kept all the garden stuff in it. And what you would do is I could lift that door just a little, okay, as it closed, and boom, it would go right into the frame. And I had another one that would always hit and be banging, and I would always find myself sort of shoving in on it. So here's the thing. It's hitting the frame and it's moving. If the frame is loose, as I do that, it's gonna move, okay? If the frame is tight, it's gonna wear or get loose. So if you think about that for a jaw, what can happen is this: the jaw closes and teeth move until they're at MIP. So I come up and I hit that, but what else happens? They can wear, they can crack, they can become sensitive, or they can fracture. So in other words, teeth are absorbing some of this closing stuff. The third possibility, the door hits the frame and the hinges move to seat the door into it, okay? This is a door actually from an office that I had at a place down in Florida. And I want you to look at this. I self-adjusted that hinge, right? But hinges come and are adjustable. Well, guess what? Your jaw is an adjustable hinge. Positional muscles move the condyle so teeth fit together at MIP. So there's the possibilities in door closing and in teeth, if we think about it. The goal is always to have all the teeth hit. because that feels and works the best. And I would say that it doesn't matter where you start from as an appropriate arc position, but if you have to make plans, you got to have a starting point so that you can plan that somehow. Now, usually what happens is some combination of the last two for people. That's real common. The frame moves, the hinges move, the door closes. In other words, people close and there's little interference things that happen. So they shift around and they keep doing things, at least until the frame falls off and the hinges come apart, right? So things like that happen or not. And the truth is, for many people who have all kinds of things I can observe going on that are quote unquote wrong, they're doing just fine. And they're not destroying their teeth, which is why my belief today is that as I think about how occlusion works, my first question is it working? We'll come back to that. The next component of a designed occlusion, once I have a place to plan from, and I've agreed that that's where I like and I want to plan from, is going to be to have posterior teeth touch simultaneously. In a case like this, you can see all the dots, and the dots look pretty much the same. I realize I'm not showing a T-scan measurement of the dots, so I don't know that they're all the same. Some of them look a little heavier. Point is this: I want it to feel like it hits all at the same time as well. Okay? I want forces directed down the long axis, which means that usually what I want to do is make sure that that cusp tip is on a receiving area down in here rather than hitting two on the side, because it could come up and clunk, but if it's hitting on the sides, forces are going to be directed outward on that tooth. And where did we see this? I'm old enough to remember I did lots of amalgams. Amalgam would wear, and where it wore, you usually wind up with broad areas of contact. And very often, as the amalgam wore, from function too, you'd wind up with occlusions just like this, where it would be hitting and coming down and hitting those two sides. And in that case, the forces are not directed down the long axis. The next thing to consider for me is that front teeth have slightly later contact. There's a little bit of freedom there. And this one is arguable, and some people don't do this. But I always try to have a bit of movement be possible. So in other words, when that cusp tip is sitting on its receiving area, there's a little bit of wiggle room there so that I get a little bit of movement. And I aim for that. And I have found that people who don't need it, it doesn't matter. So what I try to do is make sure that I can pull my AccuFilm with drag through. Some people like to take 8 or 10 micron shim stock and say, have that be clear. And the reason that I do this is pretty much just experience. What I realized was, as I was helping people feel that clunks feeling, a lot of them came back and said, I'm banging my front teeth. And if I laid them down and got them fully seated and just said, tap, tap, they're hitting everything. But their sensation is, as they are closed, they come to the front first. And that's interesting to me, because one of the things that I know, and I ask myself, is do we open and close in centric relation? Well, the answer is yes and no. Actually, when you open, I'm going to argue that you almost always begin to translate almost immediately. You open and you just translate. You shift forward a bit. Closing, often the same thing. As you close, you're a little forward. And so you might bang those front teeth. That's the sensation you get. And so for me, I always aim at this. Front teeth are going to have later contact. And then lastly, under clinch. Once, if all the teeth hit, now when I clench, nothing has to move. I can get compression of periodontal ligaments, but I'm not having to move the jaw or move teeth. In other words, I've got a stable point. That stable point could also include seated condyles, but it doesn't have to. MIP could be a place that is incredibly stable for that person. And then if I want to be able to think about how I create that, I have to have a picture in my mind of what it looks like. And so this picture is in my mind. I think about where the dots are on teeth. Where could these dots be? And I will tell you that when you aim at those dots, you don't always get those dots, as I'm going to show you, because teeth are not shaped exactly like that after people have been on the planet for a while. And as they wear, that means that some of the dots may move, but I still am looking for stability. Now, what if, think about this, if I have cusp tips in receiving areas, because as we begin to think about adjusting, and this will kind of go back to adjusting things away, because we do that. If we wax up, we put wax there, and then we adjust the wax. If we have teeth that are there and we know that we want to make everything hit, we often do the same thing. We will adjust that occlusion. If I have cusp tips in receiving areas and I want to change it, in other words, I'm not hitting everywhere, but it's in a good place, what can I do? Would I shorten the cusp or deepen the fossa? In other words, let me ask it another way. Would I flatten the point or would I dig a hole? Well, the answer to accomplish the change, if all I want to do is have more teeth hit, the answer is yes, it doesn't really matter. But I'd like you to bear something in mind. As you think about occlusions and how teeth hit, you want to always be careful to never dig a hole that you can't get out of. Now, in other words, if I take really, really long pointy teeth and I lock them in with each other, what's going to happen? They need to fly apart right away. If I make that deeper, I may have things get in the way. Now, I'm going to encourage you not to take that to mean always flatten the cusp. What I'd like you to do is look at the occlusion, because what's determining what form I can create is guidance. And guidance is the thing that allows us to say, how do those teeth separate? And then by default, how do they come together? Okay, occlusal force distribution on TMJs and teeth. This is from this study from 1976, years ago. It's still a great study. All the things are still the same. We've measured them all since. Bite force is related to the length of the lever arm. And so what's going to happen as you get further out? You're going to have less force out there. That part of guidance allows us to have front teeth touch when back teeth don't. Bite force varied by a factor of 9 from posterior to anterior. Okay, well, I think you all know that. And it's why anterior guidance is something we design in. I'm going to talk about that, but I want to go back to guidance by itself and just hit on what that really is. Because the anterior teeth are not the only guidance. I think of that, and I did for years, anterior guidance. Guidance was anterior. It was actually anterior and posterior guidance. And we want to consider those because they will let us understand what appropriate tooth form can be built. This is the posterior guidance. The posterior guidance is the angle of the eminence. In other words, the condyle's back there in the fossa and it moves around. As it moves, it's moving against an eminence, a surface. And that surface is angled. Okay, if it's steep, can you see that back teeth would fly apart? In fact, on the second molar, think about the impact of that compared to what happens on front teeth. It's huge compared to what's happening on front teeth. The steeper the angle, the more quickly the back teeth will separate as I move down that eminence. If it's shallow, back teeth separate more slowly. Think about that in protrusive. Protrusive, if I just come forward, okay, back teeth are going to separate. The back teeth separate more than the front teeth until I get up to where the front teeth are still touching. And I'm going to create a more open space toward the back. The same works when I go into a non-working movement, because in a non-working movement, that condyle is going to leave the fossa and come down along the eminence, and it will separate. The effect is bigger toward the back and less as I get forward. And if you think about it, then think about it this way. If I have a really steep eminence, those back teeth are going to fly apart. What will people's back teeth look like who have steep eminences? You often have long, pointy cusps. It looks like a long, big, deep bite. I mean, boom, they can go in and lock in, but they separate quickly, okay? If I have a shallow eminence, those teeth are going to pass by each other pretty closely. And what's the tooth form going to look like? The teeth are going to look flatter. And I'm sure you've seen all of those. Now, how do we account for that in our planning? Well, if we've used a face bow so that we can know that the upper arch is in the right place, and then we've picked an appropriate place for the condyle, what we can do is we can change this. Okay, this is called condylar inclination. And that's what happens on the articulator to mimic the angle of the eminence. And in this case, relative to this face bow, it's 30 degrees. And the way that you capture that is you do a protrusive bite record. You ask the patient to come forward, pass end to end if possible, unless they really have to come a long way, and bite down. And then I take my mounted cast that I mounted at my place that I want the appropriate position. In my world, that's almost always going to be a fully seated condylar position that you can choose to call CR. And I'm going to now take those mounted models. I'm going to open things up on my articulator and move into this bite record, and I'm going to adjust that condylar element until it touches the ball. In other words, until now I have two endpoints. I have the endpoint forward and I have the seated position. I'm going to assume it's a straight line. It's not always a straight line, but it's very close. Now when I move my models around, I am mimicking what happens for that patient, which means that on back teeth, if I'm designing cusp form, I know if they will clear. And for me, that's why I always do that. Now, anterior guidance is what happens on front teeth. This is a post-salt drawing. The anterior guidance is what's happening when front teeth are touching each other. Okay? There's two kinds of anterior guidance. Because the truth is that anterior guidance is whatever happens ahead of the condyle. That's the posterior. The anterior guidance, if it's group function, is going to include a whole bunch of teeth, including possibly posterior teeth like molars. Okay, but group function means I'm going to let lots of teeth hit. When would group function be appropriate? When would I want lots of teeth touching? Well, what if you had a canine ponic? This is from a case from years ago before we had implants. What do? Well, you have to be thinking about how you design the guidance here, because every time this person goes here and pushes out against this or comes down and chews into that, it's going to want to pull this off. So one of the ways that you can manage that is to design guidance that is spread out around that arc more. So the way that you distribute force is by spreading it out among more teeth. So we wouldn't have just the canine be the thing that touched there. What if you have a structurally weak canine? I need to share that. Okay, I have very little ferrule there. This one I have no ferrule. Tell me you never tried to do one of those. Okay, I have to think about having other teeth be involved. What about a periodontally weak canine? Yeah, well, you know, I need help. I want to spread that. So if I want to distribute the force, that's when I think of group function. Bruxers need group function. In fact, I heard a joke years ago. It has proven to be true. If you give canine guidance to somebody who's a bruxer, what do you get? Broken canines. Because they can hit on that one tooth. And they can apply all of the force that they can apply on two teeth, because they're hitting it. If you spread that force around and distribute that force, you can find a way to manage it in a lot of cases, and we've done that for years. Now, I know that today when we think about it, we think about a lot of reasons why people brux and grind, and I'm not going to go into that because this is about making teeth work. And when we decide what we're going to design, we will have made some decisions about what is the etiology of that. In a mutually protected occlusion, we try to hit only on anterior teeth. In other words, let's have anterior guidance and anterior teeth, and it is my preferred design. The reason it's the preferred design is that it works, unless it doesn't. And when it doesn't, you can find out, because things happen. It is easiest to design. Designing a group function is hard to build. And years ago, Clyde Schuyler was kind of the first person to write about it, but he said that when I found that when I was putting the initial contacts in eccentric positions on the canines and on anterior teeth, that people were destroying my prostheses much less quickly. He was a prosthodontist in New York City. And before that, I will tell you, this is back in the 20s, everything was about full group function because it was all denture occlusion. Denture occlusion was all the occlusion literature. That's what people were trying to figure out, how to make dentures work better. And what he noticed was when he got away from that and got them off their back teeth, that for a lot of people, that meant they destroyed things less quickly. They were able, excuse me, pardon me, sorry, need a drink. They were able to generate less destructive force because it was spread out, okay? Canines are going to be the guiding teeth. So for instance, the little arrow here is pointing at the centric or appropriate arc position for that condyle. Boom, that's the tap position right there. And then you can see the guidance. Let me go back and you can see the guidance. This is kind of fun because what you'll notice is I did this with Madame Butterfly silk, and when you mark this, this is the mark that I get. And what you'll notice is there's some white lines. So actually this person is kind of touching there, and then they come here, and then the main part of the contact shifts to that, partly with the, do you see the lines happening in here? One of the things I like about Madame Butterfly silk is it leaves you tons of ink. It is messy, but it allows you to read some things as well. And when I'm trying to create smooth, very often I can polish that. And then I can get some really nice things where I can get broad strokes. However, in a mutually protected occlusion, then canines become the guiding teeth, okay? If group function is appropriate, I'm going to include canines and premolars. I rarely get to molars, although I have had to do molars and build those in, but my preference is to stay with the premolars. So think about it this way. I don't want to create balancing interferences. Those are the primary things, but I would include contacts on the other side. If this is the canine out here guiding, I don't want to be hitting on this side. If I have group function on the working side, I would include the premolars. and I would do kind of progressive release, if you would. I would start out with all three, probably release this one first, then this one, and last when I get to the edge on that canine. And the idea of that is to move the guidance forward as quickly as possible because it helps to balance force. All right? Crossover is supported by anterior teeth. So one of the things I'm going to look for is that when a patient takes their mandible, and in this case shifts it out to the left, and I have my front teeth touching, I don't have contact in the back. All right? I don't want to be back in the back when I get out into crossover. And the crossover is this canine crossed over that canine. So the left crossover, my left mandibular canine crossed over my left maxillary canine, and now I'm on front teeth, which is the design that I always try to get to. I want to go from guidance onto edge to edge, and that's what's showing here. Straight protrusive on both centrals, straight protrusive should be on both central incisors, and my edges should be nicely together. Ideally, where would they hit? On mesial marginal ridges. But as I said, teeth are not designed like how we can draw them. And so I'll show you a case where you look at the marks and you go, why are they all over like that? Well, if you look at the opposing teeth, you see why. So ideally, yeah, have them hit on both. Let's bring them all forward, okay? So here's the list of things about designing an occlusion. So if we are doing that and we're designing an occlusion, let me talk about how I would walk into that. I always begin with the edge of the maxillary central incisors. I put them where I want them. This is just like facially generated treatment planning, which means it fits nicely. Make the front teeth be where you want them to be and look like you want them to look and look like teeth on both the facial and the lingual. If you do that, okay, start with the edges. Now go look at the lower anteriors. Where do you want those edges to be? I like to look at models and kind of say, well, you know, I think there's probably going to be some change here. This occlusal plane is kind of up and down. This is uneven. Anything sitting against that, if I came edge to edge, is probably not going to hit everywhere. It might because of tooth tipping, but it may not. I mean, my first guess is that it won't. Okay, and so when I look at that, I think that's probably going to get leveled off a little bit. In fact, this is kind of what I think about. This is a Monson sphere, and if you think about that, there's flow to lower arches. Some are flat, but most of them have shape to them. You can have anteriors that are a little higher, okay, and they follow a form. And as I think about that, those don't follow that flow. And my first thought is there's some stuff probably in the way there. Now, I don't know that yet, but it's the things that I always look at, and lower arches seem to show that for me. And then I want to think about how the edges are going to work, okay? There's these surfaces. There's the blue that you see here is the flat part of the incisal edge, okay? And it used to be called the pitch. And then these little edges they used to call the bevel, but if you think about it, those are all the working surfaces on a lower anterior tooth. Okay, now on the lingual on the upper, I'll show you, actually, let me show you what I mean by that. If we think about how these work against each other, here's how they work. That leading edge on the lower incisor is going to move along the lingual until it gets to the trailing edge on the upper, and then it's going to come out so that the edges work. So there it comes over, now it has to do that. So that the edges work with each other. It has to also be able to come out past, so that the trailing edge on the lower and the trailing edge on the upper work against each other. That all has to be smooth. As we do that, we're looking to make sure that the patient can move comfortably and freely. So here's an edge-to-edge position that's completely comfortable for this person. They can slide around side to side on that. Here is this person going out into a left lateral protrusive movement. And what do you notice? There's a little bit of a step here. I step over before I'm on these teeth. Okay, there I'm on it. But now what's happened here? If I ask this patient now to come back, they have to open a little because that will grab. I want it smooth. What would you change? Well, you can change either the upper or the lower. However, since the upper was designed to aesthetics and it's in the place I would like it to be, I'm going to change the lower. And as I think about it, if I change the lower over here so that I can be even there, okay, and I don't have a step, if I don't have to have a step, I'll come back to that in 1 second. I want to make sure, and often it's the case, that it doesn't interfere at all with the occlusion because there was overlap. In other words, you can still slide just the same way because this is marking down in here. So you can do some changes. Now, are steps okay? Absolutely. And I would never take out the step unless the patient had wear there. And in this case, there's wear here. The patient had been playing on that. A step is fine unless the patient hangs up. If the patient can smoothly move and come back, and not feel like it's in the way, and you don't see where, then don't change it. This is what I aim for. If I can design that so that as you come up, you step onto those centrals, that's going to be the smoothest functioning anterior motion. Okay, now recognize that that's contrived. Most people don't do that. It's a parafunctional movement, but that means that it's going to be the smoothest function when I'm chewing in that teardrop motion, and it's guiding me back in. Smooth is the thing I'm after. This is a friend of mine. In fact, the person I think who did this is on watching. All right, and this shows you how teeth can get locked together. This is going over and locking those edges in. You see, how did they become like that? Like that. So the patient goes there and plays with that. If we want to create smooth, I want you to think about this. Think about having two marbles. If I put a flat spot on each marble, and I put the flat spots together, and I have you hold them between finger and thumb, and I say squeeze, go ahead and squeeze. How hard can you squeeze? Hard as you can, right? If you turn them around so the flat spots are on your finger and your thumb and you squeeze, what's going to happen? They're going to come apart. When they come apart, your muscles don't have anything to push against. I want to talk about mechanical advantage. Smooth lessens mechanical advantages. If I apply force and something moves, I can't apply more force. So in this case, by shaping things so they transition smoothly and line up with each other, you wind up reducing the mechanical advantage that could be gained by going out and grabbing those spots, okay? The other thing that we often hear is in shallowing or lowering that angle. And the reason I will just tell you about that, the greater the angle, the greater the force, okay? So if I have things that have to go on a relatively flat surface compared to a very steep surface, all right, and this is from Williamson, what they found was, Weinberg put numbers to it, for every 10-degree change in the angle is a 35% change in force applied. What I mean by that is even if upper teeth or lower teeth moving against those teeth like this, okay, it takes more muscle force just to move them on that angle than if it's flat. If it's flat, they move freely. So shallowing guidance is always about removing energy, removing force from the system. And that's why appliances are often designed to shallow the guidance so that we can remove some of the energy in there. When we do all of those things, what we do is create more ease of movement. Okay, and if we want to go to that and we look at the models first, we go to create it on the models first. I showed you this one earlier. I love to go in and kind of start drawing on what do I think is in the way. And when I do that, I can tell you that doesn't look like it goes there. That looks like that's going to be something that's in the way. What I found is if I look at lower arches and I say, how do they look? And something's sticking up, if I color that with a pencil, by the time I'm done, that's either gone or everything else is sort of up even with it. And in this case, we shape the upper anteriors how we want them. Okay, we put some lower anteriors so they worked against those uppers, and we go in and we adjust the teeth so they fit against each other. And what you see here is this one has been mounted so that the posteriors on the upper can be removed so that you want to see what will happen when you get anterior coupling. There's a first point of contact in the posterior. Now, if you have full control, then just go in and create it with wax. So facially generated treatment planning tells me that's where I'd like those teeth to be, okay? Put them there, wax them. Create mandibular anteriors designed also, where would I like those incisal edges to be? I like them to be about there, and then I'm gonna make them touch the upper. But I'm gonna start out actually by getting my edges where I want them. I'm gonna move them end to end. Okay, and I'm not gonna change the uppers, because the uppers, I've got the incisal edges that I like. Let's make these incisal edges work. And then move around on them, slide all around. Close the articulator now at MIP and create anterior contact. Make sure that those still couple. What am I going to change? Well, if I really like those lowers edge to edge and I like the anterior posterior position, to get a little play there, I might go to the upper and say I need actually to change this prep to accommodate so that I can get contact. I would alter the lingual of the maxillary anteriors when I'm thinking about that. Okay? Don't alter mandibular anterior teeth if you like where they are. Change what you have to do on the upper to accommodate that. Then create posterior teeth that contact at maximum intercuspal position, wherever you're planning from. Move the articulator through all movements and confirm that posterior teeth separate as I move around and everything is smooth. Now, this is when you had total and complete control. Okay, you could build it into your dentistry when you have that. That's equilibration. It's been done. Now, you also can go create it on teeth. And in this case, once the case has been designed, it can actually make a little mold. And what I'd love to show you here, it doesn't show up. This is like a little roof. This is actually sticking out and showing me where this edge needs to be because it has to be higher here too. And that was built up. Okay, and so you can make plans and then transfer that to teeth, which is kind of fun, and then go in and make it work on teeth. Now, I was taught some rules, and so I'm going to talk about the rules real quickly. There was the bull rule, and I'll let you just read real quickly. You can read faster than I can talk. That was what the bull rule is for. Don't memorize it, please. This is the Lubbock rule, L-U-B-L, for lingual slides. This was for anterior slide. It was the muddle rule. I'm going to bet you heard the rules just like I heard the rules. And back in the mid-'80s, I heard somebody who reiterated those rules and then said, you know, the rules are fine, except I sometimes feel confused by the rule. I'm trying to think of how does this accommodate the rule. But in truth, if I just looked at where teeth hit relative to the arc that I like, go in and look what marks and grind the marks. Or if you have a T-scan, read it and say, where would I like to change that? For me, I like the patient to grind in red and then tap in green, blue, or black, because I find for what eyes can see, those colors cover red better and I can read it better. You do whatever you like. Some people like to grind in black and tap in red. Perfect, okay? The idea is take off the red in the back for me. So if I'm gonna have somebody bite down and grind around and then tap, I'm gonna take the red off in the back. As long as they're at my tap point. Even out the dots then. When they tap, I want nice even dots as part of that process. Now, do you always get ideal dots? No, look at this. Those dots are really nice and even, but they're not ideal dots because the teeth are not shaped like ideal teeth. Now, I said earlier, what happens if you have everything nice and touching, okay? Well, what if it's the other thing where it's even, it hits, boom, but all the teeth aren't touching? You can add some stuff. See, add composite. So let's think about it this way. I start equilibration and I start occlusal design with edges. And then this is my flow. I'm gonna walk through the flow. Adjust edge to edge and excursions, sliding all around on those edges. So I'm gonna go all over the place. I wanna make sure nothing hits in the back, and I'm gonna go on my edges and make sure that I can stay on those edges and that it's smooth. If there's a bump, it's okay, as long as the patient comfortably moves over the bump and there's not a wear facet there that tells me they've been playing with it, which means I have to somehow smooth and shape that. On the one that I showed you, I could angle that canine a little to see if you could climb that easier if the patient locks there as they come back. The lower canine could be polished and rounded. Create even posterior contacts and tap on all posterior teeth and on canines. Okay, and once I have that and everything's nice and even, well, now I have some decisions to make. Because when is that completed? When all interferences to tap are eliminated. What I mean by that is as soon as I get enough tight teeth touching so that is really solid and the clunk is there, then I look more closely. I'm looking for everything to hit. Okay, I try to aim for at least stopping when the canines hit each other. When the cuspids hit contact, I got to stop and reevaluate. And in this case, what you notice is there's a bunch of teeth not touching. Okay, so what if all the teeth are not touching? What are you going to do? Well, you have some choices to make. You could continue to adjust, which means you're going to close the vertical down some more, and that may be just fine, and it might be wholly appropriate. You could restore to create contact. Okay, you could restoratively change that. You could move the tooth or teeth. You could move the bone, right? Or you could leave it alone. And I will tell you that on equilibrations, frequently, as soon as there's no distortion, when the patient loads, there's nothing that moves, they tap, but they're still not hitting everywhere, I will usually try to see how close it is. So I'll start folding over my paper just to see. But the truth is this, you can leave them low and watch them grow. But while you do that, you want to be careful not to leave them high and watch them die. Okay, I don't want to leave things isolated so they get isolated. But if I have all the contacts, and I have, say, 2 pairs of teeth that are not quite in contact, let's just let them come into contact because teeth want to hit each other. Number 3, eliminate lateral contacts on posterior teeth. Now I really got to look at my grinding around. I did edges, I got tap. Let's start grinding around. I don't want red in the back, I want the dots. And then same for protrusives. So for me, grinding around is not just side to side, it's forward. And if I think about it, what I'm looking for is stripes in back, dots in back, stripes in front. Stripes in front, dots in back. Here's the stripes. Then I want to harmonize the anterior guidance and make sure that it's nice and smooth. This is a very smooth anterior guidance. How come it doesn't look nice and uniform and bilaterally symmetrical? Well, because if you look at the lower teeth, that's what the teeth are shaped like. But if I have the patient move, there's no tooth movement. I can put my finger on there, nothing's being pushed on. it's smooth and the patient can do it nice and easy. Smooth to me is still the most important thing. Then if I've had them laying back, let's sit them up and have them tap, tap and slide around. And let's see if they bang front teeth first. So I'll usually take some red and say, well, you know what, just tap, tap. And I'll see, and what you notice over here, sometimes I'll get contact and I have to create some freedom. And that is the little lighter on the anterior that I discover. And then if I lean them back and have them tap, tap in black, I often will get a mark that's back further. Let's give them a little bit of freedom on that so that when they first close, they can hit everything. And that's called postural freedom. And then polish it until it's smooth. Did you know diamond polishing paste, the literature says, will give you the same smoothness as glazed porcelain. I can vouch for that. It'll feel really, really smooth when polished. And then there's my list. That's my process. That's how I look at equilibration, at designing an occlusion, because it's the same thing for me. Okay? Making it smooth. I start to see that teeth move smoothly against each other. Usually what you begin to see, because form follows function, is you begin to see teeth that look really nice. And here's some teeth pre and post equilibration. Everything moves smoothly and you can see things look nice and smooth because they work against each other smoothly. Okay? And form follows function. Now, how do you learn to do this? You got to practice. Okay? Get some mounted models and start playing with them. And there are two very important lessons I was taught by two of the masters who are my mentors about learning an occlusion. And apologies, Madeline, it was already in here because I say it all the time. And those of you who have ever spent time with me know that. The first one is this: the biggest obstacle to learning is not ignorance. It's the illusion of knowledge. Are you willing to go into something not having to know everything so that you can just set your mind free and try? And the second one, this is not aimed at you, Madeline. I always say this: the learning is in the doing. And it was taught to me by one of my teachers who would say, just go do it, Gary, and then come and ask me questions, because then the questions can be different. He was right. Here's the thing that I think about when I think about occlusion. Is there one right answer? Because isn't that what you're looking for? It's what I was looking for most of my life. I'm going to say yes, there is. I'm going to give you my version of occlusion is simple. This is my version of occlusion is simple. If it's working, why would I ever change it? If dentistry is needed, where am I changing it? And the question really in that is, will the changes I make interfere with stability? And then lastly, if it's not working, how am I going to change it? So for me, the right answer is why, where, and how. Someone much smarter than me also made that statement. Occlusion is simple. They asked him to write a book. They said, would you write a book on occlusion? And he said, well, no, because occlusion is simple. And that was L.D. Pankin. And I'd like to share with you what I learned from him about this. When the jaw is closed, all the teeth contact at the same time. When power is applied, neither teeth nor jaw deflect. In movements away from this fully contacted position, no back tooth hits before, harder than, or after front teeth. Any occlusion you can think of will be accommodated within that statement. That's pretty profound. He then said this: now you must learn when to apply those principles appropriately to each individual patient you have the privilege to serve. It is simple, but it is not easy. I hope you enjoy listening to this as much as I enjoy doing it. Now let's have a glass of wine, and I'd be happy to answer some questions. Thank you. I'm watching, there's a couple there, so I'm not sure who's here with me. Pascal, how nice to see you here. What a wonderful treat. Thank you, sir. I'm going to stop sharing, and I'm not sure who's here, but I'm going to change my view to gallery view. And if there are some questions, I'm happy to answer them. Raynell, do you want me to read them?
Sure, if you don't mind. My dog is going crazy.
I don't mind at all. All right. When you check for the fit of the bite and evaluating occlusion, what position is the patient in? Do you have a protocol about this? Well, I would argue this. If they're laying back, okay, I I would argue that, at least for me, and I'm doing bilateral manipulation, I want to make sure that I have their condyles seated, because sitting up, they would tend to come forward a little unless I'm seating those condyles. My routine, because I like the leaf gauge for almost everything, is it doesn't matter, because it's directed by muscles that they're closing against the leaf gauge. So I guess that I would say, the great answer to every question that can be asked is it all depends, right? So most of the time, it doesn't matter for me, because I'm going to use a leaf gauge or a Lucia jig, and that's going to be driven by muscles hitting against something and taking teeth out of the loop. What steps do you take in the impression and planning wax-up phase when you develop occlusion on routine cases, like single posterior units? So the question there is, I got to tell you, most of the time, treat them in MIP. If nothing is wrong with their occlusion, why would I ever change it? If there are occlusal issues, that's a whole different discussion to get into, a single posterior restoration. Now, what if they have occlusal issues and a single posterior restoration? I would want to know what those issues were before I started my single posterior restoration, particularly if it was a second molar. What if that's the first point of contact when the condyles are seated? There's wear between that first point of contact and MIP, and I'm going to go treat that tooth. I'm nervous. Okay, that would make me wonder. So I would say this, part of my evaluation with every new patient is an occlusal evaluation, including when condyles are fully seated, what teeth can they touch? That's part of my evaluation so that I know that ahead of time, okay? And to me, that becomes the routine. About 3 more minutes, good. Since the lower anteriors are not in an ideal position, why not use orthodontics to correct the position of the teeth, then adjust if needed? Amen. Yes, amen and amen again. Absolutely, totally. My first choice is always to move teeth rather than reshape them or restore them. But if I can reshape or and restore and get the same occlusal result, then those are options for the patient and for me. But I still would love to just move teeth to where they go, because everything is easier. And I'm not saying that because I'm married to an orthodontist. All right. Is this the same as long centric? Yes, actually, long centric is the thing you're thinking about when you think about the freedom, the wiggle room that I talk about. Yes, that is essentially long centric. Thanks for reminding us of simple foundations. A number of patients have MIP not coinciding yet. No, yes, amen. Thank you, Pascal. And I appreciate hearing that from somebody who's been doing it for a long time and understands that. It's so easy for us often in teaching to get tied into saying this is how it has to be. And the truth is that I found that occlusions, if they're working, can have so many issues, quote unquote, if you will. In other words, here's a person who hits on only a few teeth, and yet there's no wear, there's no tooth mobility, there's nothing happening. What is the goal? The goal is to help that person be able to function in maximum comfort, function, health, and aesthetics for their whole life. Okay, if it's working, why change it? Have you heard of the approach for bad joints where the patient's mandibles postured for 6 to 12 months, allow retrodiscal tissue to heal, and then are moved back to a seated position? Yes, I have. Temporary myocentric phase avoids the need for muscle brace bites. Yes, and I will tell you that lots of times on appliances, when I start with an appliance, you're starting in a forward position because that's where the patient's posturing because they're comfortable. And that as things settle down and adjust, you will find a new position. In fact, that is especially important, and Jim McKee and I are teaching the advanced occlusion course around the fact that you can't just go in and say, just because I can get somebody there, that's where they should be. If the disc is out of place, we have to find a place where that patient goes to where it works, and that's stabilizing thing. And to me, that's using appliance therapy. Okay. Restoring a crown that has a non-working interference that is not causing a problem. Would you replace the non-working interference in the new crown? Usually not. At least I wouldn't. Your title was Occlusal Equilibration. What's the definition of equilibration versus adjustment? Well, I guess for me, and thanks again for asking that, Pascal, equilibration became for me all of the things that I used to think about in any of that. A traditional equilibration would be picking up my handpiece and reshaping teeth to make them fit together better. That was the traditional learning that I had. But today I think about that handpiece is not my only tool. Today, if I sit down and I do a wax up, I think I'm doing an equilibration if I'm working on occlusal surfaces. In fact, I'm going to argue that every person who's watching this does equilibrations every day. Every day. Do you do any class 2 composites that include marginal ridges or ridges that occlude with the opposing arch? When you get done putting that in, is it perfect every time? In other words, here, like the form is just what you want, The dot is right where you expect it when they bite. Thank you for laughing. I hope you're laughing. No, you pick up a handpiece and you shape it. If I'm waxing, I pick up my carver and I carve it. I guess to me, equilibration and adjustment is kind of all the same thing. It's all tied together. It's creating all of those things that were on my list. Okay. I think I have time for one more. I'm going to do one more. It says 5 o'clock. Hi, doc. So if you're treating a single posterior tooth and treating an MIP or using a triple tray impression, and let the lab design occlusal design and we adjust day of treatment, MIP, I expect that it's going to be extremely stable. I love triple trays, so I would use a triple tray. I've found that a really good technician can sort of figure out what the form of the occlusal should be in movements by looking at the teeth around it. That gets harder on a terminal tooth, in other words, a second molar if there's no third molar there. Having said all that, if the MIP is stable, then I probably am not going to have that much adjustment to do. I would hope I would have almost none in tap-tap. And what I do have to check is the excursions, correct, because I can't check that with the triple tray. And I think that's the question that you're asking. If MIP is stable, I love MIP. But if I'm treating enough teeth that I have to be concerned that I might disrupt that stability, then I have concerns. If one of those teeth that I'm treating, I know is in the path from first point of contact to MIP, and there's wear, I'm more nervous. If I know all those things ahead of time, I can look at patients and talk to them differently. I don't have any more time, and if I don't stop now, Raynell will cut me off. And I will say thanks for being here, everybody. Raynell probably has some closing things about, are they doing an evaluation or anything, Raynell? I'm sorry, I'm sort of lost on this one.
No, just, I did post a link for Spear Online if they are interested.
Okay, so cool. So if you go to the chat, is that where you posted it?
Yeah, I can post it again. I think it might have gotten lost.
She'll post it again. If you're interested in Spear Online stuff, where we talk about stuff like this a whole lot, then please go there and look up and see what we're doing here. Darren, Pascal, Madeline. I didn't have time to read all the names, and I see a lot of other friends. Hi, Brent. I want to thank you all for being here. This is really, really fun, and it's fun seeing you all. I miss you all. I wish we could still be doing things at the center. I can't wait to get back together. Everybody stay safe. Try and have as much fun as we can in this. Be well. God bless you all. I look forward to seeing you in person when that's possible.